Cardiac arrhythmia is defined as the disturbance of electrical rhythm of heart. So there is a normal electrical rhythm of heart, which we were discussing in the first class. And so this heart rate, when it is more than 100 per minute, it is known as tachycardia. And when it is less than 60 per minute, it is bradycardia. So the normal heart rate is between 60 to 100 per minute. When it is more than 100, it is known as tachycardia. And when it is less than 60, it is known as bradycardia. So what is arrhythmia? Arrhythmia, when the pathology affects the conduction system of heart, it is known as arrhythmia. You all know about the conduction system of heart, which we were discussing in the first class. So there are three main mechanisms of tachycardia. We are dealing with tachycardia, which is increased heartbeat. So there are three main mechanisms of tachycardia. One is increased automaticity, next is re-entry, and third is triggered activity. So in some of the questions, it will be there that the mechanism of tachycardia is 1, 2, 3, and all of the above. Okay, it is increased automaticity, re-entry, and triggered activity. So you see, in normal sinus rhythm, that is when the heartbeat is between 60 to 100 per minute, what happens is, so you can see two tracks, one is A and B. So there will be, this is a cardiac muscle, this is the SA node, and we will be seeing the AV node downwards. So what happens is, this impulse will be coming like this, and in the SA node there will be two tracks, A and B. So in A, it is a smaller track and the impulse will be quick. Here the in B, what happens is, it will be B conducts rapidly, but the recovery is slowly. In A, the recovery is faster. So what happens is, when there is refraction, the same thing continues. That is, in A, the recovery is it conducts slowly, but the recovers quickly. And in path B, what happens is, it conducts rapidly and recovers slowly. So there is no problem. That is, the heart is in normal rhythm. That is between 60 to 100 per minute. But in case of premature impulse, what happens is, A will be normal. So A will be normal. But what happens to pathway B? What happens to pathway B is, premature impulse will be in the pathway B and B is closed. B is closed. So this cannot move here. So it becomes premature. That is, normal impulse is not taking place and the pathway of B is closed. In re-entry phenomena, what happens is, this A will be coming before B. A will be coming before B and it will be traveling towards the AV node. It will be traveling towards the AV node faster. AV node faster. And also, since the B is not conducting, this A will be conducting towards B. Here the B is closed and the A will be conducting towards B. It is known as re-entry phenomena. Normally, it should come like this and it should go downwards only. Here what happens is, it will be coming downwards as well as it will be going towards B. It is known as re-entry phenomena. And in case of tachycardia, what happens is, this re-entry phenomena again go towards the B. Again go towards the B and it take the opposite direction. It is known as tachycardia. So what happens when the impulse takes the opposite direction? There will be more muscular activity leading to increased rhythmicity of heart, which leads to tachycardia, that is above 100 per minute. I hope you understand. So the thing is, there are this much of mechanisms are there: premature impulse, re-entry, and tachycardia. So what happens is, instead of normal heartbeat, there will be additional heartbeats, which leads to increased heart rates per minute. So the next thing is sinus arrhythmia. Sinus arrhythmia is a normal thing. It is not a abnormal thing. So in sinus arrhythmia, what happens is, there will be increased heart rate during inspiration and decreased heart rate during expiration. This is a normal thing which is happening place in a normal human being. So what happens is, there will be increased heart rate during inspiration and decreased heart rate during expiration. And when there is absence of this normal phenomena, it is known as there is some abnormality. And the conditions where there is absent sinus arrhythmia, or when there is variation, it is seen in diabetic neuropathy. Autonomic involvement in patients with diseases of peripheral nerves or increased sympathetic drive. That is when there is some nervous affection like a neuropathy or peripheral neural disease, or when there is increased sympathetic drive, this sinus arrhythmia will be absent. You remember, in sinus arrhythmia, there will be increased heart rate during inspiration and decreased heart rate during expiration. And this sinus arrhythmia does not require treatment. It is a normal phenomenon and it is more pronounced in children. We can see the sinus arrhythmia more in children. So we are going to discuss about the pathological causes of sinus bradycardia and tachycardia. So sinus bradycardia, you understand, bradycardia is there is reduced heartbeat. So there is some problem within the muscles of the heart. So muscles cannot contract properly, which is leading to bradycardia. So the most important thing is myocardial infarction. In myocardial infarction, what happens? There will be death of the cardiac muscle. Is it not? Ischemia and infarction. So it leads to sinus bradycardia. And there is sinus node disease like sick sinus syndrome. That is SA node, sick sinus syndrome. SA node is sick and it cannot transmit the impulse or it cannot produce the impulse properly. So there will be reduction in number of impulse leading to bradycardia. When there is hypothermia and the temperature of the body reduces, it leads to bradycardia. When there is hypothyroidism, so in hypothyroidism, metabolism will be affected. Metabolism will be reduced. So it leads to reduced heartbeat, cholestatic jaundice, and also raised intracranial pressure and some drugs. So the most important thing leading to sinus bradycardia is myocardial infarction, sick sinus disease, hypothermia, hypothyroidism, cholestatic jaundice, and raised intracranial pressure. Next is sinus tachycardia. That is due to the affection of SA node or sinus node. What happens is there will be increased heartbeat. So it is in anxiety. So when the patient becomes anxious, what happens? There will be increased heart rate due to sympathetic activity. And then when there is fever. So in hypothermia, there is reduced heartbeat. In hyperthermia, there will be increased heart rate. Anemia. In anemia, what happens? The oxygen will not be supplied to the organs in sufficient amount. So what happens? There will be increased heart rate. Then heart failure, thyrotoxicosis, metabolism will be increased. Pheochromocytoma due to the production of the adrenal cortical malignancy. So there will be increased production of the hormones leading to tachycardia. So in bradycardia, the most important thing is hypothermia and hypothyroidism, tachycardia, anxiety, fever, anemia, heart failure, and also thyrotoxicosis. So these are the pathological causes of sinus bradycardia and tachycardia. So what is sick sinus syndrome? Sick sinus syndrome, it occurs at any age and it is common in the older people. So what is the cause of sick sinus syndrome? So there should be something happening in the SA node. So it may be fibrosis, it may be degenerative changes, or it may be ischemia of the SA node. So when there is some fibrosis, degenerative changes, or ischemia of SA node, there will be problem. There will be problem with the conduction of the heart or production of impulse. So in last slide, we were discussing that sick sinus syndrome is a cause of sinus bradycardia. Yes, the typical presentation is palpitation, syncope due to intermittent tachycardia, bradycardia, or pauses in atrial or ventricular activity. So this is sick sinus syndrome. You remember sinus arrhythmia is a normal thing, and other than all those things, all the things other than this sinus arrhythmia is abnormal. So common features of sinoatrial disease. So what are the features of sinoatrial disease? There will be sinus bradycardia, sinoatrial block. So there will be sinus arrest. Sinus arrest means there is no production of impulse from the sinoatrial node. Sinus bradycardia will be there. There will be sinus arrest. Then there will be paroxysmal atrial fibrillation, paroxysmal atrial tachycardia. Why? This SA node is not producing the impulse. So what happens? The things which is beyond the SA node will be start producing the impulses, which leads to atrial fibrillation, atrial tachycardia, and also there is signs of AV block. These are the common features of sinoatrial disease. See, this is known as atrial. So we were discussing about the diseases of sinoatrial node which leads to arrhythmia. Now we came to the atrial musculature, pathology of the atrial musculature which leads to arrhythmia. So first is atrial ectopic beats. So here you see the first atrial beat is normal. This is an ECG where P is there, QRS complex is there, and also T wave is there. Second is also normal. Third, fourth. See, third and fourth. There is some abnormality. There is some abnormality. That is, QRS complex are normal. Here the QRS complex are normal, but the P wave is abnormal. P wave is abnormal. So in first session we were discussing that P wave is the thing concerned with the atrial function. So here P wave is abnormal and QRS complex is normal. So these are the normal atrial beats, or these are the normal heartbeat. But in between the normal thing, there is ectopic. Additional 2 beats are there with an abnormal P wave. So this is an atrial ectopic beat. That is, the atrial musculature starts beating apart from the normal conduction of impulse. Next important thing which is in concern with the atrial musculature is atrial flutter. So flutter waves, you see atrial flutter in lead 2 and lead 3, you can see these waves, sawtoothed waves, which is seen in atrial flutter. Sawtooth, the P waves will be very much this one. Next is atrial fibrillation. So we were discussing about the atrial ectopics. We discussed about atrial flutter. Next is atrial fibrillation. It is the most common sustained cardiac arrhythmia. Very, very important point. Question is, the most common sustained cardiac arrhythmia is dash. It is atrial fibrillation. During episodes of atrial fibrillation, what happens is the atria will be beating rapidly. It beats rapidly, but the beats will not be normal. It will not be coordinated. Atrial muscle will be beating as if there is something happening. There is a trigger of movements along the atrial muscles, so that it beats unconditionally and also in uncoordinated fashion. The ventricles are activated irregularly. So what happens? There is so much of impulse coming from the atria in uncoordinated way towards the ventricles. So what happens? This ventricular musculature also starts beating irregularly. So this produces an irregular pulse. So atrial fibrillation leads to irregular pulse. So in ECG, there will be irregular QR complexes and P waves. So P waves, we cannot see the P waves. And there is irregular fibrillation. So the difference between atrial fibrillation and atrial flutter is the QRS complex is almost, we can identify the QRS complex in atrial flutter. But in atrial fibrillation, what happens? The QRS complexes will be irregular. Then the common causes of atrial fibrillation. The most important thing is, the most important sustained cardiac arrhythmia is atrial fibrillation. So common causes of atrial fibrillation include coronary artery disease. The common cause of atrial fibrillation include a coronary artery disease, including acute myocardial infarction, valvular heart disease, especially rheumatic mitral valve disease, hypertension, sinoatrial disease, hyperthyroidism. So see, in case of atrial fibrillation, hyperthyroidism, there will be increased heartbeat, tachycardia. So it is also seen that it is also hyperthyroidism also leads to atrial fibrillation. Alcohol, cardiomyopathy, congenital heart disease, chest infection, pulmonary embolism, pericardial disease. So these are the common causes of atrial fibrillation. And the most important thing is coronary artery disease, including acute MI. So this is an example of atrial fibrillation. In A, what happens is there is fast ventricular rate. So ventricular rate is fast. You see the QRS complex, the ventricular rate is faster. That is between 120 and 160 per minute. It is between 120 and 160 per minute. In another case, there is in chronic atrial, so this is an acute atrial fibrillation A. In chronic atrial fibrillation, the ventricular rate is smaller due to effects of medication. You understand? So this is an example of acute and chronic atrial fibrillation. And in acute atrial fibrillation, QRS complex will be very much more. That is between 120 and 160 per minute. But in case of chronic atrial fibrillation, due to the medication or due to the AV nodal setting, the QRS complex will be much slower. So you see, this is atrioventricular nodal reentrant tachycardia and Wolff-Parkinson-White syndrome. Wolff-Parkinson-White syndrome is very, very important. So in case of, you see, in AV nodal reentral tachycardia, what happens is the impulse will be starting from the SA node. And what happens? See, the impulse should be going like this, but here there will be re-entry of the impulse, within the atrium. So in AV, this is right atrium, and there will be re-entry of impulse within the right atrium in case of AV nodal re-entral tachycardia. But in case of Wolff-Parkinson-White syndrome, in Wolff-Parkinson-White syndrome, it is divided into 3 types. First is sinus rhythm, second is orthodromic tachycardia, and third is atrial fibrillation. So in case of Wolff-Parkinson-White syndrome, what happens is this SA node, this is SA node, and the impulse will be traveling downwards in sinus rhythm. So what happens is that it will be the accessory pathway. There will be an accessory pathway, and the ventricles will be depolarized in a uniform fashion. Although there is normally it should come like this. Although here there is a accessory pathway, the ventricles will be depolarized in a normal fashion. But in case of orthodromic tachycardia, what happens is there will be re-entry through the additional band. Re-entry through the here it will be coming towards the ventricles. But in C, what happens is instead of coming through the ventricles, it will be going through the additional pathway. In case of D, what happens is there will be so many re-entry. It is atrial fibrillation. So there will be so much of re-entry, and some of the thing will be traveling to the additional pathway. So you understand in Wolff-Parkinson-White syndrome, what happens is there is a additional pathway which connects the atria to the ventricles, or within the atria and ventricles. So what happens is this impulses will be traveling in a visceral fashion. You see the ECG. In case of AV nodal reentry tachycardia, the heart rate is so much. In case of Wolff-Parkinson-White syndrome, sinus, the heart rate will be normal. But the QRS complex, there is visceral, and also P waves are affected. In case of orthodromic tachycardia, increased heart rate is there, and also P waves. This QRS complex is affected along with the P waves. But in third, atrial fibrillation, you see some of the fibrillatory waves are only seen. This QRS complex is visceral, and also P waves cannot be identified. So this is Wolff-Parkinson-White syndrome, where there is an additional tract which connects the atria to the ventricles. Now we are going to discuss about the causes of long QT interval and torsatus de pointus. So what is torsatus de pointus? Torsatus de pointus, it is something in relation with the ventricular tachycardia where the QT interval is prolonged QT interval, or QT interval is long along with the this ventricular tachycardia. So you understand, when you hear about or when you see about torsatus pointus, you just understand that torsatus pointus is the ventricular tachycardia. It is a type of ventricular tachycardia along with the prolonged QT interval. So causes of long QT interval and torsatus pointus: bradycardia. Bradycardia compounds other factors that cause torsatus pointus. That is, when there is bradycardia, it leads to ventricular arrhythmia or ventricular increased rate leading to torsatus pointus. And when there is electrolyte disturbance like hypokalemia, hypomagnesemia, or hypocalcemia. So when there is everything is hypo. Okay, hypokalemia, hypomagnesemia, or hypocalcemia, calcium, magnesium, potassium. So when there is when everything is hypo, it leads to torsades de pointes. And in case of some drugs, there will be torsades de pointes and also some congenital syndrome. So you remember bradycardia and electrolyte disturbance. Here, electrolyte disturbance is very, very important. Electrolyte disturbances when there is reduced potassium, reduced magnesium, and reduced calcium. So next we are going to the another important thing regarding the arrhythmia. Another important thing that is first degree heart block. In first degree heart block, the only thing we can see is PR interval. So PR interval is prolonged. This is P wave. This is P wave. This is R. So this is PR interval. It is prolonged and measures here. It measures 0.26 seconds. So the only thing which we can see in first degree atrioventricular block or first degree AV block is prolonged PR interval. So this is second degree heart block. This is very, very important. Second degree atrioventricular block. It is also known as Mobitz type 1 and second degree atrioventricular block. There is two types of, one is Mobitz type 1 and also Mobitz type 2 atrioventricular block, second degree atrioventricular block. And this Mobitz type 1 is also known as Wengi-Back phenomena. So there are two types of second degree atrioventricular block. One is Mobitz type 1 and second is Mobitz type 2. Mobitz type 1 is also known as Wengi-Back phenomena. So here you see, here the PR interval prolongs until a P wave is not conducted. See, here there is P wave, QRS complex, PQRS, PQRS. So there is increased distance and see here there is no P. So prolongation of the PR interval one by one until the P wave is not conducted. So there will not be conduction of the P wave. So this cycle repeats itself. This is known as Mobitz type 1 or Wengi-Back phenomena. So the distance of the PR interval or the distance of the PR interval increases one by one, and there will be absent P wave. Again, here the PR interval is increasing and there is absence P wave. So this is known as Mobitz type 1 or Wengi-Back phenomena. In second degree heart atrioventricular block or Mobitz type 2, what happens is the PR interval is normal, but some P waves are not conducted. So where there is conduction of P waves, it will be normal, but somewhere there will not be conduction of P wave. It is known as Mobitz type 2. In Mobitz type 1 or Wengi-Back phenomena, what happens is there will be prolongation of the PR interval in sequence, and once what happens is this P wave will not be conducted. But in case of second degree atrioventricular block, what happens is this P will be conducted or no, and somewhere this P wave will not be present. It is known as Mobitz type 2. Mobitz type 1 is also known as Wengi-Back phenomena. Then next is complete atrioventricular block or third degree atrioventricular block. So what happens is there is complete problem in this P wave and also QRS complex, and somewhere QRS complex is present, somewhere it is not present, and P wave is there. But QRS complex takes a desired thing. So it is complete degree or third complete heart block. So you remember in first degree heart block, you cannot see anything except prolong the PR interval. In second degree heart block, it is divided into two, Mobitz type 1 and Mobitz type 2. Mobitz type 1 is also known as Wengi-Back phenomena, and this Mobitz type 1, this PR interval will be prolonged, and at some point this P wave will be, we cannot see the P wave. In type 2, Mobitz type 2, what happens is P will be normal in the conducted waves, but some point this P waves will be absent. And in complete heart block, third degree heart block, it will be bizarre. So we are going to the causes of complete atrioventricular block. Congenital causes and acquired causes will be there. Congenitally, there will be atrioventricular block itself, and it is a congenital one. And in acquired causes, when there is idiopathic fibrosis, myocardial infarction or ischemia, inflammation such as infective endocarditis, sarcoidosis, Chagas disease, and also trauma, it leads to complete heart block. So these are the causes of complete atrioventricular block or third degree heart block. Then we are coming to the bundle branch block. So we were discussing about the ISA node, atrium, AV node, ventricle. Now we are coming to the bundle branch block. There are two types of bundle branch block. There are two bundles, is it not? Bundle of is, that is branch. So right bundle branch and left bundle branch. In right bundle branch, the causes of right bundle branch block is normal variant or right ventricular hypertrophy or strain. So when there is right ventricular hypertrophy, leads to right bundle branch block. When there is congenital heart disease such as atrial septal defect or coronary artery disease, there will be right bundle branch block. In left bundle branch block, the causes are coronary artery disease, hypertension, cardiomyopathy, and the aortic valve disease. So these are the causes of bundle branch block, right and left. See, right coronary artery disease is a cause, but in left bundle branch block, the main cause is coronary artery disease, hypertension. So in case of right bundle branch block, what we can see is there will be M-shaped configuration. QRS complex will be having M-shaped configuration in V1 and V2. You see V1, so there will be M-shaped configuration of the M-shaped configuration V1 and V2. So M-shaped configuration of a QRS complex in V1 and V2 is seen in right bundle branch block. Right bundle branch block. And in case of left bundle branch block, there will be M pattern in V5 and V6. So in right bundle branch block, there will be M-shaped QRS complex in V1 and V2. But in case of left bundle branch block, there will be M-shaped pattern in V5 and V6. So you remember this. Then we are going to valvular heart disease. So we came to the conclusion of this arrhythmia, which includes so for refreshment, disturbance of electrical rhythm of heart. It is the disturbance in conducting system of heart. When it is more than 100, it is tachycardia and bradycardia. So we were discussing about the mechanism, sinus arrhythmia, causes of bradycardia, sick sinus syndrome, common cause of sinoatrial node, then atrial fibrillation. The most important thing is the most common sustained cardiac arrhythmia is atrial fibrillation. Common causes, then Wolff Parkinson White syndrome, very important. Then heart block, Mobitz type first degree, second degree, Mobitz type 1 and type 2. Mobitz type 1 is also known as Wengi-Back phenomena. Then complete heart block, and common causes of bundle branch block, and how we will be identifying the bundle branch block. In V1 and V2, when there is same pattern, it is right bundle branch block, and V5 and V6, when there is same pattern, it is left bundle branch block. Next, we are coming to the valvular heart disease. So we are discussing about the causes of acute valve failure. So the causes of acute valve failure, aortic regurgitation. The cause of aortic regurgitation, the most important thing is aortic dissection and infective endocarditis. You see, aortic dissection and infective endocarditis. In mitral regurgitation, it is due to papillary muscle rupture due to acute myocardial infarction or infective endocarditis or rupture of chordae due to myxomatous degeneration. Then when there is prosthetic valve failure, that is mechanical valves such as fracture, jamming, thrombosis, dehiscence, biological valves, degeneration in the cusp. So these are the causes of acute valve failure. Aortic regurgitation. So infective endocarditis is a cause of acute valve failure, which is more seen in aortic regurgitation and also mitral regurgitation. Then we are going to discuss about the principal causes of valve disease. So valve regurgitation. What is regurgitation? The blood will be flowing in the opposite direction. So the use of valve, why valve is there in the heart? It prevents the backflow of blood. That is, blood will be flowing from one chamber to the other chamber only. There is no backflow of blood. So it is the use of valve in the heart. So in regurgitation, what happens is this blood will be there will be backflow of blood. That is, blood will be flowing in the opposite direction. So regurgitation, the causes of valve regurgitation are congenital, acute rheumatic carditis, chronic rheumatic carditis, infective endocarditis. So all the carditis, acute rheumatic, chronic rheumatic, and also infective endocarditis. When there is cardiac failure, syphilitic aortitis, traumatic valve rupture, senile degeneration, damage to colon. And what are the causes of valvular stenosis? It is congenital rheumatic carditis and senile degeneration. So the most important thing which has more causes is valve regurgitation. So valve regurgitation is the one which occurs when there is all these diseases. But in valve stenosis, it is congenital rheumatic carditis and also senile degeneration. So here this is rheumatic fever. Rheumatic fever is very, very important as far as valvular heart disease is come. When we are considering the valvular heart disease. So these are the clinical features of rheumatic fever. So it causes St. Vitus dance or Sydenham's chorea. Very, very important. St. Vitus dance or Sydenham's chorea. There is a history of sore throat. There is flitting polyarthritis. Flitting means there will be this polyarthritis shifts from one joint to another. There is carditis, dyspnea, syncope, pericarditis, and the murmur is known as Carey-Coombs murmur. Very, very important. The murmur of rheumatic fever is Carey-Coombs murmur. Then aortic or mitral regurgitation and a heart block will be there. And there is subcutaneous nodules over bones or tendons, and there is fever. And there is erythema marginatum. So these are the features of rheumatic fever. The important things are Sydenham's chorea, Carey-Coombs murmur, flitting polyarthritis, subcutaneous nodules, erythema marginatum, and also carditis. So there is something known as John's criteria, where we are very much will be knowing all these things. Anyway, for refreshment, we are seeing John's criteria of rheumatic fever once more. So Dr. John's is the one who are given this criteria, and it consists of major manifestations and minor manifestations. So major manifestation, carditis, polyarthritis, chorea, erythema marginatum, and subcutaneous nodules. Minor manifestation include fever, arthralgia, raised ESR or raised CRP, previous rheumatic fever, leukocytosis, and first degree atrioventricular block. Supporting evidence of preceding streptococcal infection, recent scarlet fever, etc. So this is John's criteria. So one major manifestation and two minor manifestations. Then we are going to mitral stenosis. So the clinical features of mitral stenosis includes breathlessness, fatigue, edema, ascites, palpitation, hemoptysis, cough, chest pain, and thromboembolism. So this mitral stenosis is the most important thing is mitral stenosis is the one which causes hemoptysis. Hemoptysis, very, very, very important. Only cardiac cause of hemoptysis is mitral stenosis. I repeat, the cardiac cause of hemoptysis is mitral stenosis, none other than mitral stenosis. And signs are there will be atrial fibrillation, mitral phases, then mid-diastolic murmur. So we were discussing about the murmur in the previous session, which you will be remembering. There will be mid-diastolic murmur, pulmonary edema, pleural effusion, and also right ventricular peak and louder P2. So you remember all these things: mid-diastolic murmur, mitral phases, atrial fibrillation. And the thing which you should remember is the cardiovascular thing which causes hemoptysis. The cause of hemoptysis in relation to cardiovascular diseases, mitral stenosis. Next, we are going to mitral regurgitation. So in mitral regurgitation, what happens is there will be ascites, which is different from that of mitral stenosis. Ascites, edema, palpitation, fatigue, and restlessness. And the murmur is pansystolic murmur. Pansystolic murmur. You remember these things only. And there is raised jugular venous pressure in mitral regurgitation. And the murmur is pansystolic murmur. But in case of mitral stenosis, it is mid-diastolic murmur. Next, we are coming to aortic stenosis. In aortic stenosis, what is the murmur? It is systolic, ejection systolic murmur. So in aortic stenosis and mitral, so in last class we were discussing in aortic stenosis and mitral regurgitation it is systolic. In mitral stenosis and aortic regurgitation it is diastolic. So here there is mid ejection systolic murmur, exertional dyspnea, angina, sudden death. Everything is okay, but you remember this murmur. Okay. And Cardiacum's murmur, you remember, is it not? The Cardiacum's murmur, it is in rheumatic fever. Next is clinical features of aortic regurgitation. So this aortic regurgitation is a very, very complicated thing and it consists of so many signs. So we are going to revise all those signs. Okay. So mild to moderate aortic regurgitation, it is often asymptomatic with palpitation. In severe aortic regurgitation, there will be breathlessness and angina. And signs. So there will be so many signs in aortic regurgitation regarding the pulse. So it is collapsing pulse, large volume. The pulse will be collapsing. So what happens is in case of aortic regurgitation, there will be backflow of blood. Is it not? Backflow of blood, which leads to increased pressure all over the body, leading to, we can see the pulsations everywhere in the body, and these pulsations can be seen everywhere in the body is represented by signs. So this pulse, so there will be large volume or collapsing pulse, large volume or collapsing pulse, large volume or collapsing pulse. Then there is low diastolic and increased blood pressure, pulse pressure. Then there will be bounding peripheral pulses. Then capillary pulsations can be seen in the nail bed. It is known as Kyunki sign. These signs are very, very important as far as this aortic regurgitation is considered. So when there is capillary pulsation in the nail bed, so we can see that the nail bed of the patient is pulsating due to increased capillary pressure. It is known as Kyunki sign. Kyunki sign. Next, there will be femoral bruit. So in femoral artery, you can hear bruit, and it is known as Durosi sign. Durosi sign, femoral bruit. When there is head nodding with pulse, so what happens is due to this increased pressure, each beat there will be nodding of the head. The patient's head will be nodding. It is known as D-Mussett sign. D-Mussett sign. So three signs. So there will be collapsing pulse, bounding peripheral pulse, and when there is capillary pulsation in the nail bed, it is known as Kyunki sign. When there is femoral bruit, it is pistil short. Femoral bruit or pistil short femoral artery, it is known as Durosi sign. And when there is head nodding with the pulse, it is known as D-Mussett sign. Then murmurs. Murmurs are early diastolic aortic regurgitation. Yeah. Aortic regurgitation, it is early diastolic murmur. There is sometimes systolic murmur, and the murmur is known as Austin Flint murmur. Cardiacum's rheumatic fever, Austin Flint aortic regurgitation. And other signs are displaced heaving apex beat. So apex beat will be displaced. Then pre-systolic impulse, fourth heart sound, crepitation. You remember all these signs: Kyungi, Durosis, D-Mussett sign, collapsing pulse, pistil short, early diastolic murmur. See, you know the aortic man. He is known as the aortic man. Okay. And he is with full of signs. Okay. So we'll see the signs one by one. So lighthouse sign. What is lighthouse sign? In lighthouse sign, you see here in the forehead of the patient, you can see a red mark over the forehead of the patient. Lighthouse, that is, there will be increased pulsation in the forehead. It is known as lighthouse sign, like the light of the lighthouse, which comes and goes. Which, there will be light, and for some time there will not be light. So it will be blinking. Light will be blinking like that. Pulsation will be there in the forehead of the patient with aortic regurgitation. It is known as lighthouse sign. So we know about D-Mussett sign. Is it not? What is D-Mussett sign? The patient will there will be nodding of the head along with each pulse. It is known as D-Mussett sign. Then Landolfi sign. What is Landolfi sign? Yes. So Landolfi sign, there will be above the eyes. So there will be pulsation. Then Becker sign, inside the pupil there will be pulsation. Then Muller sign, that is pulsation of the uvula. Corrigan's neck sign and Corrigan's pulse, that is there will be what here, which artery is there? Carotid artery. There will be pulsation of the carotid artery. Corrigan's neck sign or dancing carotids. Dancing carotids. Then Rosenbach sign. So there will be pulsation of the liver. Gerhardt sign. There will be pulsation of the spleen. Kuhnke sign. What is Kuhnke sign? There will be pulsation of the capillary. Then de Rossi sign. So we were discussing about the de Rossi sign in the last slide, and de Rossi sign is the femoral vein, and pistal short femorals, and Trop sign. All is in concern with the femoral artery, and Hill sign and Mayen sign, which is in the BP of the patient, and also there is water hammer also. You remember all these sign, it is seen in aortic regurgitation. This is the aortic man where we have lighthouse sign, Landolfi sign, Becker sign, Muller sign, Corrigan sign, Rosenbach sign, Gerhardt sign, Kuhnke sign. So you remember this man. So that Rosenbach and Gerhardt is very, very important. Rosenbach is liver and Gerhardt sign. Dancing carotid is also known as Corrigan's neck sign. Lighthouse sign, D Musset sign is nodding of the Muller sign, that is the pulsation of the uvula along with each pulse. So here we were discussing about the John's criteria. John's criteria, where John's criteria is in a rheumatic fever. In rheumatic fever, you remember the Caddy-Coombs marker, Sydenham's chorea, St. stand. And John's criteria for diagnosis, major is and a minor is there. Major is carditis, polyarthritis, chorea, erythema marginatum, subcutaneous nodules. Minor includes fever, arthralgia, raised ESR or CRP, previous rheumatic fever, leukocytosis, first degree AV problem. Then mitral stenosis, you remember mitral stenosis, the murmur is mid-diastolic murmur. And the important thing to remember is the cardiovascular disease which leads to hemoptysis is mitral stenosis, very, very important. Then mitral regurgitation, there is pansystolic murmur. In aortic stenosis, ejection systolic murmur will be there. And the aortic regurgitation. Aortic regurgitation is a very complicated thing with so many signs. Important is, these are the signs which are explained in the Davidson, and this I have took from the internet. This man is known as aortic man, and you remember all these signs are seen in aortic regurgitation. In other stenosis and regurgitation, these signs are not there. In aortic regurgitation, it is a dancing carotids, Corrigan sign, Muller sign, Becker sign, Landolfi sign, lighthouse sign, D Musset sign, water hammer pulse, Rosen. These are very, very important. These signs can be asked in the question. So this is regarding the infective endocarditis. So this shows the clinical features of infective endocarditis. So infective endocarditis, what are the? So there is chance of cerebral emboli, Roth spot, very, very important. Roth spot, ROTH, Roth spot in the fundi. So there is hemorrhage, okay, hemorrhage everywhere. So hemorrhage and also emboli. So cerebral emboli, Roth spot, very, very important. You remember raw spots which are seen in typhoid, in the abdominal muscles. Raw spots. This is Roth spot. Seen in Roth spots in fundi, which is rare. Then petechial hemorrhages on mucous membrane, pure dentition. There is splenomegaly. There will be systemic emboli, digital clumping, splinter hemorrhages, loss of pulses, petechial rage, and the nodes of endocarditis, infective endocarditis is Osler's nodes. Osler's nodes in rheumatic fever, we are discussing about the subcutaneous nodules, but in here, Osler's nodes, which are seen in the pulp of the fingers. Osler's nodes seen on the pulp of the fingers, hematuria, cardiac failure, conduction disorder, fading murmurs, and also subconjunctival hemorrhages. So these are the clinical features of endocarditis, infective endocarditis. So this infective endocarditis and also this rheumatic fever are all the causes of, so we were discussing the causes of valvular heart disease, and so I am discussing here, and also in Davidson it is discussed here. Okay. Rose spots is hemorrhages everywhere. Hemorrhage everywhere. Okay. So Osler's notes. You remember Osler's notes? You remember Caricum's murmur in what? Caricum's murmur in rheumatic fever. Okay. Then diagnosis of infective endocarditis. So it is known as modified Duke criteria. Modified Duke criteria. So in modified Duke criteria, there is major criteria and also minor criteria. In major criteria, positive blood culture. So typical organism from two culture, persistent positive blood culture taken less than 12 hours apart. Sorry, greater than 12 hours apart. 3 or more positive cultures taken over greater than 1 hour. More than 1 hour. So major criteria, there should be positive blood culture and also endocardial involvement. So endocardial involvement, positive echocardiographic findings of vegetations and new valvular regurgitation. So in infective endocarditis, bread and butter appearance will be there, and also presence of okay. Minor criteria, there will be predisposing valvular or cardiac abnormality, intravenous drug misuse, then pyrexia, that is fever, embolic phenomenon, vasculitic phenomenon, blood culture suggests organism grown but not achieving major, suggests echocardiographic findings. Modified Duke criteria. Patients with 2 major or 1 major and 3 minor or 5 minor have definite endocarditis. Patients with 1 major and 1 minor or 3 minor have possible endocarditis. So when the patient is having 2 major or 1 major and 3 minor or 5 minor, there is definite endocarditis. That is, the patient is suffering from endocarditis. If there is 1 major and 1 minor or 3 minor, there is chance of endocarditis in this particular patient. So here we comes the end of this session. Today we have been discussing about the valvular heart disease as well as the arrhythmia of the heart. So next we will be discussing about the congenital heart disease. So next session we will complete the cardiovascular system, where we will be discussing about the congenital heart disease, our diseases of aorta, myocardium, and also important points regarding the cardiovascular system. So hope you understand this class. Thank you, Dr. Regine, for giving me this opportunity. Thank you so much. Hello. Hello, Regine.